Boswellia gets sold like the quiet miracle hiding behind frankincense. Less inflammation, less joint pain, maybe even better cartilage. Before we get dazzled by the incense to immune system story, what is the most honest headline for someone with achy knees who wants relief, but not hype?
The honest headline is Boswellia may modestly help knee osteoarthritis pain, stiffness, and function for some people, but it is not proven as a general anti-inflammatory cure. The stronger data are symptom scores in small randomized trials and meta-analyses, not hard endpoints like avoiding surgery, rebuilding a damaged joint, or reversing arthritis across the board. Also, Boswellia is not one molecule. It is gum resin from Boswellia species, most often Boswellia serrata, in supplement trials. Extracts concentrate boswellic acids and related compounds, but two bottles can differ in resin source, standardization, dose, and absorption technology. That is why trial results do not automatically transfer to any online capsule with a tree picture on the front.
So how would a tree resin swallowed as a capsule plausibly reach a sore knee? Is the story mainly immune chemicals in the joint, pain nerves getting less reactive, or cartilage metabolism changing in the background?
Mechanistically, the most believable route is inflammatory modulation. Osteoarthritic joints are not just worn-out hinges. Cartilage, bone, synovium, and immune signals talk to each other. Boswellia extracts are studied for effects on inflammatory mediators and cartilage degradation markers, which could translate into less swelling, stiffness, and pain sensitivity. That is plausible biology, not proof that the resin becomes a joint repair material. A 2026 pilot trial asked a sharper question: does Boswellia change pain processing itself? 12 healthy volunteers took 300 milligrams twice daily for 28 days. Then researchers used capsaicin to provoke pain. The primary pain intensity endpoint was not significantly different from placebo, with visual analog scores that were close. So this study supports curiosity about pain modulation, not clinical confidence.
If someone is already taking anti-inflammatories, blood thinners, diabetes drugs, immune medicines, or has surgery coming up, is Boswellia casual enough to self-start? Or should it go on the medication list first like any other biologically active product?
For knee osteoarthritis, the evidence is more encouraging than that pain model study. A 2025 network meta-analysis of 39 randomized trials across 7 supplements ranked Boswellia highly and found significant improvements versus placebo in WOMAC pain, stiffness, function, and VS pain. But rankings can exaggerate confidence when the underlying trials are small, uneven, or using different formulations.
Those numbers sound impressive, but what would a person actually notice? Are we talking less morning stiffness on stairs, fewer rescue pills, a better 6-minute walk, or the kind of dramatic pain reset that supplement ads often imply?
The most realistic target is a meaningful nudge. Less pain with walking, less stiffness after sitting, and easier stairs. In a network meta-analysis, Boswellia's mean differences versus placebo were statistically significant across WOMAC domains and VS pain, but those pooled numbers combine different scales and products. I would not promise a specific point drop from a random label. Cartilage claims need extra caution. 180-day placebo-controlled trial of standardized Boswellia extract, SN 13108F or aflipin, reported better symptoms, 6-minute walk, stair climb, MRI cartilage measures, and lower hsCRP and cartilage degradation markers at 100 milligrams daily. Interesting, yes. Definitive proof of cartilage rebuilding for all Boswellia products, no.
When the evidence is this extract-specific, how should someone choose a product without pretending the supplement aisle is a pharmacy? What label clues are actually useful, and which phrases are just decorative plant language?
Useful clues are the exact extract, amount per day, and standardization marker. Trials in this packet used very different approaches. Aflipin at 100 milligrams daily, a Boswellia celery combination with 300 milligrams Boswellia plus 250 milligrams celery extract, and a healthy volunteer pain study at 300 milligrams twice daily. Dose only means something when the extract is named. Combination studies are useful but messy. A turmeric Boswellia formula reduced posture-related low back soreness over 15 days, and Boswellia-containing combinations were studied after breast-conserving surgery and with physical therapy in NEOA. Those results may reflect synergy, the other ingredients, rehab, or study design. They should not be counted as pure Boswellia evidence.
If a clinician says it is reasonable to try, how would you run the experiment? What should someone measure so they do not mistake a good week, placebo effect, weather change, or a quieter exercise schedule for proof that the capsule worked?
I would first screen for pregnancy, allergy history, liver or gastrointestinal vulnerability, multiple medications, anticoagulants, immunosuppressive therapy, and upcoming procedures. Reported trials in this packet did not show major safety signals at study doses, but small trials miss uncommon harms. Stop and seek care for rash, breathing symptoms, significant stomach upset, bleeding, or unusual bruising.
So the verdict is not frankincense fixes joints. It is, for mild to moderate knee osteoarthritis, a well-labeled Boswellia extract may be worth a monitored trial if usual care is in place and expectations are modest. Is that the fair landing?
Yes, I would treat Boswellia like a time-limited, evidence-informed adjunct. Choose a transparent product, track knee pain and function for several weeks, keep the rest of the plan steady, and stop if there is no meaningful daily life improvement. The win condition is easier movement with acceptable safety, not proving that a supplement slogan was true.